Good evening, everyone. I welcome you all for today's webinar on recent updates in medical oncology 2025. For the welcome note, I would like to invite Dr. Manish Sharma. He's a consultant and head of unit medical oncology, Positron Super Specialty and Cancer Hospital, Rohtak. The stage is all yours, sir.
Good evening. Thank you for joining at this evening. Uh, so the topic for today is recent updates in medical oncology, and the cancer in focus is the lung cancer, which is indeed the most common cancer worldwide. And we have multiple treatment available, personalized treatment available for this disease entity at the moment. So with us is Dr. Praveen Jain. He is senior consultant and head medical oncology at Akash Healthcare Institute in Delhi, and he will be speaking on the optimizing treatment in advanced EGFR mutant lung cancer. Dr. Praveen, I welcome you. Good evening.
So thank you, Dr. Manish. Thank you for giving me this opportunity. Let me share my screen. I hope my screen is visible.
Yes, sir.
Let me just. Okay, 1 second, please. Let me hide this panel. Okay. So good evening, everyone. So I'll be speaking on optimizing treatments in advanced EGFR mutated non-small cell lung cancer. To introduce the topic, so EGFR mutated non-small cell lung cancer. So this is one of the most common oncogene-driven type of non-small cell lung cancer. The frequency of EGFR mutation, it varies according to the geographical regions. So in Asian population, EGFR mutation rates are close to 40% and 20% in non-Asian population. Among the EGFR mutations, EGFR deletion 19 chromosome and L858R, which is the 21 exon. So these are the two most common mutations, and they are classified as a common mutation. Rest of other mutations, be it exon 20 insertion, exon 20 mutation, or S761Q, or the compound mutation, they are classified as uncommon mutations. So these EGFR mutation, they are located in the tyrosine kinase domain, and they result in increased kinase activity of EGFR, which ultimately leads to cell proliferation. So there are various EGFR TKIs which are available. So we have first generation TKI where we have two drugs, erlotinib and gefitinib. We have second generation TKI where we have afatinib and decomitinib, and we have the third generation TKI and osimertinib. So there are slight bit of difference between the first, second, and third generation TKIs. And the difference is according to the inhibition of the wild type and inhibition of the mutant strains. So usually the first generation TKI, they have majority inhibiting effect on the EGFR mutant cell lines, and the wild type EGFR inhibition is less. If we look at the second generation TKI, so it also inhibit both wild type and mutant EGFRs. So, but the action of these drugs, second generation TKI, so they have a irreversible covalent binding. So because of which there are more adverse events like rash and diarrhea. Osimertinib, which is a third generation TKI, it is a mutant selective drug, so which mainly inhibit the mutant EGFR. It has very little activity on wild type EGFR, and that is the reason it has very low adverse events as compared to the second generation and third generation. second and first generation TKI pertaining to the wild type PGFR inhibition. The other peculiar thing about the third generation TKI is that it has got irreversible covalent binding to mutant EGFR, and the third one is that it has got a very good CNS penetration, because of which it has got a CNS activity, and this drug is active against brain metastasis as well as the leptomeningeal metastasis. FLORA was the registration trial for osimertinib in the first line management of metastatic non-small cell lung cancer who are having the sensitive EGFR mutations. So this was a randomized double blind phase 3 trial. So here again a tabulation of first, second, third generation TKI. So here we are able to see that the first and second generation TKI, they both have activity against wild and mutants EGFR both, and they have minimal efficacy, a minimal ability to cross the blood-brain barrier as compared to the third generation TKI, where the blood-brain barrier penetration is significant. So again, it shows that the third generation TKI, osimertinib, it is active against EGFR mutant cells, then EGFR T790M mutation also, and it has got a lower activity against the wild type EGFR, and it also crosses the intact blood-brain barrier. So this was the FLORA study design, where they had included those with locally advanced unresectable or metastatic non-small cell lung cancer with common mutations. The mutations were exon 19 deletion or L858R, and they had also included the stable CNS metastasis. And the patients were randomized into osimertinib versus EGFR TKI, the standard of care, which was the first generation TKI, and they were randomized in 1:1 fashion. The primary endpoint of this trial was progression-free survival, and there were a variety of secondary endpoints related to the efficacy, related to the safety, and the CNS efficacy. This was the primary endpoint where there was a significant improvement in favor of osimertinib. The median PFS was 18.9 months versus 10.2 months, and the hazard ratio was 0.46. Looking at the subgroup analysis, so almost all the subgroups, they had almost equal advantage as far as the PFS was concerned, and osimertinib fared significantly better as compared to the EGFR TKI SOC. Looking at overall survival analysis, there was a significant overall survival, and this is for the first time that in EGFR mutated space, the median OS has crossed 3 years. The median OS with osimertinib was 38.6 months as compared to 31.8 months with the SOC. And almost 54% of the patients as compared to 44% of the patients, they were still alive at 36 months. Looking at the progression-free survival at 3 years, or those patients who are continuously taking osimertinib at 3 years. So there was tripling in that number, 9% with the first generation TKI and 28% with the third generation TKI. This was the secondary endpoint, time to first subsequent treatment, which was again prolonged with osimertinib with a hazard ratio of 0.478. So again, a tabulation of clinical subgroup according to the PFS and OS analysis. And we can see among the OS analysis, there are certain points where the activity of osimertinib is not very, very clear. But again, these are exploratory analysis. They are thought-provoking. But at this point of time, osimertinib works in almost all the subgroup. And the subgroup which I'm talking about is Asian versus non-Asian, where the Asian population did not do as well as compared to the non-Asian population. And those patients who had L858R, so they also did not do as well as compared to those with exon 19 deletion. So osimertinib's PFS benefit was clearly maintained across all subgroup. all overall survival subgroups showed a positive benefit, except which we have talked about. So the question arises, why do we think it is important that patient receive osimertinib in the first line? So here is the mathematics or calculation. So there are studies which shows that approximately 30% of all patients who are eligible for osimertinib as second line treatment for T790M mutation positive non-small cell lung cancer following progression on a first generation or second generation TKI. So approximately 50% of those patients who are alive and who are able to get an accurate test will get T790M positivity. So we cannot predict which patient are going to have the T790M positivity, which are not having. And some patients, they do not get that far. And only 70% of the 60 to 70% can receive an accurate T790M test. So in total, only three-fourth of the patient they receive some second line therapy, and out of those three-fourth of the patient, so only 50% they turns out to be positive, and almost 30%, so the 30 to 50% they are able to get a T790M result. So looking at these number in totality, so almost three-fourth of the patient they will receive second line therapy, out of which two-third they will have a T790M results, out of which 50% they will have a T790M positivity status. So out of 100%, only 30% they will be eligible for second line osimertinib, and 70% they will be left behind this. And it is seen that all patients they are not able to receive a valid T790M test. So there could be many reasons. So there could be that the plasma testing was false negative, so there is no site where a rebiopsy can be done, or a rebiopsy is challenging, or rebiopsy can lead to significant amount of complications. Sorry. And these are the studies which had eluded on this point, that 80% of patients screened for Aura 3 trial, they had a valid COBAS EGFR mutation test results. In the trial by Chouad et al., so rebiopsy was not possible in 20%. So the approximate number as far as the real world studies are concerned, it is 20% to 30% of the people, they will not be able to have a valid T790M results. So there is another concern that the Flora trial crossover was allowed. So those patients who had initially treated with osimertinib, so they were treated with second line some TKI, but those who were treated with first generation TKI, so they were allowed to receive osimertinib in the second line, depending on the T790M result. And we can see over here that 31% of the patient in experimental arm, they could not receive a second line therapy. And in the so we can see that 29% they received EGFR TKI other than osimertinib, and 68% cytotoxic chemotherapy. So if we look at the standard of care treatment, so 31% of the patients in the standard of care treatment, they received second line osimertinib. So a crossover rate of 31%, and despite that, there was an overall survival advantage which was seen with this trial. So again, a tabulation of all the phase 3, phase 2 trials of EGFR TKI, which consistently shows that one-third of the patient, they do not receive a second line therapy in phase 3 clinical trial. So in a real world study of patient with EGFR mutated non-small cell lung cancer, the risk of not receiving second line therapy is quite high. So this was a retrospective study of Germany, where 130 patients were treated with the first line EGFR TKI, and only 112 patients they were candidate for second line therapy, out of which 30% of these patients did not receive second line therapy. So the number which was there at a limit of 15 to 20% in the trial setting, so it was 30% with the real world setting. and the reason could be many. So it could be patient refusal, it could be poor performance status, it could be fast progression and death. So approximately 30% of the patient in the real world, they do not get a valid T790M results. So this slide shows that only few patients, one third or fewer patients, they receive second line osimertinib, and we can see all these analysis where the results are consistent to have the second line osimertinib receival of 15 to 30%, not more than one third of the patient they receive second line EGFR TKI. Comparing it with Archer 1050 second line treatment versus Flora second line treatment, we can see that those patients with dacomitinib arm, so they receives first line EGFR TKI was received by 100%. So almost 50% of the patient, they did not receive any second line therapy, and only 10% of the patient they received the second line or third line EGFR TKI. So looking at the gefitinib arm, again 40% of the people, they did not receive any second line therapy. So similar was with the Flora also, where osimertinib arm, 50% of the patient, they did not receive any second line therapy. And in the EGFR TKI comparator arm, almost 35-40%, they did not receive second line. So a significant number of patients, they do not receive the subsequent line treatment. So this is the comparison of all the therapies when taken together. So what is the survival with the first line versus second line osimertinib? So above is the osimertinib as a first line therapy, which gives us 18.9 month of PFS. After that, there is chemotherapy, which gives us PFS. So in below, so there is SOC GFR TKI, which gives 10.2 month of PFS. After that, if patient is eligible for osimertinib, so then again the patient will get approximately 8 to 10 months of PFS, and then chemotherapy, which will be almost slightly lesser than the osimertinib first line. But the catch here is that 70% of the patient, they will receive only chemotherapy after the first generation TKI, and the median overall survival in these patients, it is going to be very less as compared to the first line osimertinib. So the key or the take home message is that osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. So it is the first trial where the median PFS advantage has finally translated into an overall survival advantage. It has also improved overall survival versus first generation EGFR TKI in untreated population. Osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. Osimertinib is very well tolerated at 80 milligram dose, and the AE leading to dose reductions, they are infrequent, and sequencing cannot be considered the best strategy, as almost two-thirds of the population, they will never receive osimertinib in the subsequent line. With this, I would like to end my talk, and this is the final slide. NCCN guideline recommends osimertinib as a category 1 option. So if there are any questions, I'll be happy to answer those. And thank you for patient listening. Back to organizers.
Dr. Praveen, thank you for that lucid presentation. So we have the data of Mariposa available with us in the first line setting, which shows significant advantage, PFS as well as overall survival advantage versus osimertinib alone. So how do you see this data? Vis-a-vis, we have the data for chemotherapy plus osimertinib also, which has got the not still proven OS, but has the PFS which is almost equivalent to that of Mariposa. So do
Yes.
you see that this is the practice changing or
See,
way shift
there
shifting?
are issues with these trials. So number one, so the median PFS with Flora 2 versus the median PFS with the Mariposa, they are almost equal. So they are close to 24, 25 months. So we do not have the overall survival result yet. So the only thing is the cost of Mariposa regime versus the cost of Flora 2 regime. So there is a vast difference between the two. And moreover, lazertinib also is not available in India. So technically, if theoretically, if we look at it, so I think my go-go choice is going to be I'll use first Flora 2, and after that, maybe the regime of amivantamab along with chemotherapy.
I think that is true. Amivantamab plus lazertinib has multiple side effects as well, and it needs multiple infusions every week or twice a week. Apart
And
from
the
that, you
cost,
rightly said,
India is a very price sensitive
yes, it is
area.
very, very much. And moreover, I think we don't know the kind of mutations or resistance mechanism which happens after amivantamab plus lazertinib versus the mechanism of resistance which happens after osimertinib plus chemotherapy.
So another thing is, Dr. Manish, that after using osimertinib, so there are almost one fourth of the patient who gets MET amplification or MET aberrations. So
Mm,
amivantamab is able to take care of those resistance mechanism at least. So this is again a point which we consider while selecting our second line therapy after osimertinib. But looking at all these, so it is not very clear on amivantamab plus lazertinib. So what are going to be the resistance mechanism? How are we going to deal with those resistance mechanism? So I think the science is still evolving, and sooner or later we will get that answer also.
okay, thank you so much, Dr. Praveen. Uh, our next speaker is Dr. Pankaj Goyal. He is senior consultant at RDCI-RC, and I invite Dr. Pankaj to have his next session on overview of lung cancer. Sir, good
So,
evening.
yeah, good evening. Yeah, thanks a lot. I hope that my screen is visible.
Yes, sir. Yes.
So I'll just share the slide. Just a minute. So thanks a lot, organizers, for having me here. We'll have an overview on lung cancer. So we know the burden of lung cancer in India, as per 2022, is high, as we see that lung is responsible for the number of cases, 5.5%, and number of new cases around 8% of total population. That makes it around 51,675 cases. Optimal staging is required. There have been minor changes in the staging because of the outcome what we see at present, and the treatment options have also been changed because of that. So these are the standard tools of investigation which we usually advise to the patients: bronchoscopy, CT chest, PET scan, EBUS, midostoscopy, and MRI brain in few cases. So depending upon the location of the nodes, we can ask for any of these tests. Usually PET scan and MRI brain is done for most of the patients. So lymph node more than 1 centimeter are better predictor for malignancy. CT scan alone has limited role because of sensitivity is low, 55%, and specificity is 81%. So it helps in selecting appropriate procedure for tissue sampling. PET-CT, on the other hand, is around 90% sensitivity and specificity. So central tumor in size of the tumor and higher SUV on PET, that signifies how likelihood node will be positive. So with SUV 0.0 to 4, 1.9, both the patients are diagnosed to have N2 metastasis. More than 4, 10 out of 95. So if the size increases, then chances that it will be having a positive report will be better. So clinical tumor size and two nodes, if more than 6 centimeter, then more than half of the nodes are actually positive. Middle sternum staging, this is less invasive. We have a lesser invasive option, that is EUS and EBUS. Middle sternoscopy conventional, we have different ways, including VATS. So if there is clinical suspicion of N2, involvement remains high even after negative EBUS, then surgical staging of the mediastinum is done. So when is invasive mediastinum staging indicated? In central tumors, more than 3 centimeter, extensive infiltration of the mediastinum, bulky N2, or on chemotherapy, then we need not do invasive confirmation. We can take it as positive. Discrete N2, yes. And the middle signs, this is the algorithm that if the patient is having intranasal lung cancer with enlarged lymph nodes, Then mediastinal lymph node has to be seen. If it is negative and we have low probability, then we can go ahead after we have seen on the PET. If that is N1C or N0 and higher probability of unforeseen N2, then we go for EBUS. So if it is negative, then we can go for mid anoscopy as well. And if the mediastinal lymph nodes are positive, then if they are obviously bulky, then we can leave. Otherwise, we can go for EBUS and then decide accordingly. So lymph node status accessibility has been shown here. There are few lymph node stations in which this mediastinoscopy will be having upper hand as compared to the other locations. Like cervical mediastinoscopy is better for 10R, and left VATS is for 10L, and right VATS is for 9 and 11R. So these are the specific few indications where we see that they have a better role if we talk about the VATS or mediastinoscopy. So we have these different sensitivity, specificity of these lymph nodes depending upon their location. And if PET scan is done, then that is having a sensitivity of 80%. And if EBUS is added, it is 89%. And if EBUS, EUS, and all mediastinoscopy is done, that is 94. So not in all patients, depending upon the location of the tumor and the suspected lymph node, we can choose whatever test we want to do. NSCLC was once considered single disease, and clinical relevant to treatment planning from diagnosis. So this is the breakdown how we divide this into squamous, small cell, or adenocarcinoma and adenocarcinoma. Specifically, so we go for molecular profiling, and depending upon that, we decide whether the patient is a candidate for any molecular-based medicine, or depending on the PD-L1 TMB score, we can offer PD-L1 inhibitors. So advances in management of NSCLC improve survival a lot. We see when lung cancer specific survival improved from 20% among men that were diagnosed in 2001, and it has increased to 39% who have been diagnosed in 2014, and now it's even better. So thanks to the newer generation medicines and investigation modality what we are having. A significant increase in approvals of both targeted as well as immunotherapy and SLC can be seen. So this is the flow chart where we see that we had numerous drugs started from Jeftinib, Seratinib, then we had this Dabrafenib, Alectinib, Osimertinib, Leralectinib, Entrectinib. Then we have these agents which are we have started using recently like Bigatinib, Capimetinib, or Selpercatinib. So and also PD-L1 inhibitors. We have now a plethora of PD-L1 inhibitors like Pembro, Nivo, Atizo, and Durva. So this is the way now we go for most of the times NGS, where we check for more than a dozen mutations to see whether the patient can be candidate for targeted therapy. So increase the need of molecular testing in NSCLC. Molecular testing has now become a standard of care. So it's not like just to check GFRL, preferably NGS to be done. So recommended chemotherapy treatment options, we know that uh, in stage 2B, specifically, so when nodes are positive or T size more than 4 centimeter, then adjuvant chemotherapy is indicated. And if it is N2 disease, then we have to add radiation as well. So it should be a multimodality treatment, and decision should be between a radiation, medical, and a surgical oncologist. And then we should decide whether which patient should be operated upfront or which patient needs chemotherapy and what should be the sequence. And if because if there is incomplete resection, then at times we have to go for a resection. So after initial treatment, more than half of the patients recur in within 5 years. So we have to make sure that we give best of the therapies so that the patient does not have a recurrence. So latest ESMO guidelines recommend adjuvant chemo for more than 4 centimeter tumors. And due to clear evidence of the benefit, what we can see in these patients, when we see there is survival benefit in these patients, more than 4 centimeter. And LACE meta-analysis also showed that there was a OS benefit in post-operative cisplatin in early stage NSCLC. And now this is a bit controversial. You can say whether the patient should be given neoadjuvant chemo or they should be addressed locally upfront. But neoadjuvant therapy versus adjuvant chemo difference is not much. So it depends whether the patient has surgically resectable or not. Targeted therapy is now moving to early stages, as Dr. Praveen has already elaborated about the DORA trial. We see osimertinib in the resected EGFR in SLC, and it has shown a marked improvement in the survival and 80% reduction in the risk of disease recurrence. If the patient is continuously on osimertinib, hazard ratio being 0.20. It also shows the improvement in DFS and as well as OS in adjuvant setting. It shows the improvement in survival in adjuvant setting in patients who have PD-1 more than 1%. We see that at 36 months, it improved from 48 to 60%. Then radiation, we have these various modalities, including IMRT. And what's relevant is that the radiation should have lesser impact on the lung, whatever is remaining after surgery, so that the patient doesn't have much of symptoms. So these are the radiation types. 4D CT planning is done, image guided radiation therapy, adaptive radiation, and contemporary RT techniques in stage 3. The long term OS results from RTOG 0617 are favorable. We see that the OS has improved as compared to the previous decades. Chemotherapy with radiotherapy is standard of care after complete resection in stage 3 NSCLC that is being used now routinely along with the PD-L1 inhibitors wherever it is indicated. So, stage 2 is chemotherapy, and if N2 disease, then radiation has to be added. Preferably, we can choose whether sequential or it should be together. Checkpoint inhibitor are also moving in early stage. We see the Pacific trial, which we have been using the durvalumab, which demonstrated OS improvement of 42.9% in comparison to the historical OS in acceptable 3 NSCLC, where it's the 5-year survival is just 15 to 25%. So we have these target therapies in immunotherapy which are further improving, and 50% patients with advanced non-squamous NSCLC will have a driver mutation with an FDA-approved agent. So it's always good to check these tests. So we have these wonderful drugs. We talk about osimertinib, which is still first-line therapy, 0.46 hazard ratio. We have Alex trial, Crown trial, crizotinib, and alectinib 0.43. Then we have metexon, skipping mutations. We use crizotinib, RET rearrangement, kibostinib, and mandatinib, then anti-RK inhibitors like leralectinib and trectinib. And HER2 mutations, 2 to 4% of the patients will have, and we see edotrastuzumab doing very well in that. So survival outcomes in targeted therapy, we see that they have improved the survival a lot. Where the survival was hardly a year, it's crossing 2 years, 3 years, depending on whatever therapy we are using. So it's been reported as high as even see 40, 45 months, 50 months in the patients who have these driver mutations. Immunotherapy, we have these CTLA blocker drugs in combination to PL1 inhibitors. So we have this pembrolizumab combination, atezolizumab, nivolumab. Then we have this other combination nivolumab plus ipilimumab in PD-1 more than 1%. Then atezo alone in more than 50%. Nivo plus ipli in metastatic or recurrent NSCLC with 2 cycles of doublet followed by singlet. Then survival outcome also we see with ICI have improved a lot, and we see survival increasing from few months to 2 to 3 years in most of these studies. Checkpoint inhibitors have improved survival in advanced NSCLC, as we see that it hazard ratio being 0.62 and the 60-month survival improving drastically from 66 months to 81 months. Checkpoint inhibition is moving to early stage. As we discussed, we have various trials for Membro, Durva, Nibo, Atizo. Initially, it was Durva. Now we have other options also. So in NSCLC, what is new? They are approved therapy for these ADC binding agents, which act on these cells. CAR T cell therapy. This is initially, I think, phase 1 too early to bank upon it, but then we are having some studies on the CAR T cell therapy also. Key takeaway message: the management landscape is fast changing in NSCLC. Newer therapies have a huge potential to improve survival, especially when detected in early stage. OS has improved across various subtypes with molecular alterations. The ease of oral pills over infusion in cases of targeted drugs is an added advantage. Pulmonologists will play a huge role in early diagnosis, and it is crucial to involve them in the tumor boards. With that, I'll conclude my presentation, and thanks a lot for patient here.
Sir, thank you so much for that overview on lung cancer. So, I have a patient with BRCA mutation in lung cancer. So, do you think that it is
I
going to
think
work?
I think not in the first line, but second line, we should definitely use these agents.
Right.
Yes.
And in the neoadjuvant setting or adjuvant setting, do you consider giving just 3 cycles of nivolumab because it has also shown survival advantage, or continue with the whole 1 year of the
So depending
treatment
upon
with,
the
with the
affordability, we choose whatever regime we are using. So till now, we are using the 3 cycles of nivolumab because the cost effective, that is one of the options, and I think we have decent results with that without reduction.
Okay. Thank you so much, sir. So next, I will be presenting the role of osimertinib on the adjuvant lung cancer treatment. So I will be sharing my screen. So my screen is visible.
Yes, sir.
Okay. So good evening. I will be speaking on reinventing adjuvant therapy in EGFR mutant early lung cancer. So the survival outcomes in the resectable NSCLC, it needs to be improved. And the lung cancer is the leading cause of cancer death, as already told by previous two speakers. It accounts for almost 1.8 million deaths annually. And the NSCLC represents approximately 80% of all the lung cancer diagnosis, with an estimated 30% of all the patients presenting with the resectable disease at diagnosis. And the 5-year overall survival rates with the patient
हेलो
in
हाँ
resectable
सर ये
NSCLC.
डॉक्टर अभिषेक यादव इनका फोन स्विच ऑफ आ रहा है मुझे
Hello, your phone is on. You are on mute. So the global 5-year overall survival rates in the patient with resectable NSCLC are 65 to 75% in stage 1B, 50 to 70% in stage 2, and 30 to 45% in stage 3A. So almost 70% patient in stage 3, they will relapse once they have completed their treatment. So these are the treatment recommendations in the early stage lung cancer, and this is the expert consensus recommendation on the biomarker testing in metastatic and non-metastatic NSCLC in Asia. So these patients, they should undergo a PET CT scan to look for the staging of the disease, MRI brain, and then if it is a resectable disease, the EGFR and PDL1 mutation should be done. It should also be seen that whether it is exon 19 or L858R mutation, or both are positive, or one is negative, or both are negative. So this is the current treatment, testing and treatment pattern. Prevalence of EGFR mutation with resected stage 1 to 3 non-squamous NSCLC. This is a result from the early EGFR study. It was presented in ASCO 2023. The EGFR mutation prevalence was 51%, with deletion 19 the most common, that is 50.5%, followed by L858R. And this study enrolled consecutively patients with surgically resected pathological stage 1A to 3B non-squamous NSCLC between March 2021 and October 2022 at 33 centers across Middle East, Africa, Latin America, and Asia. So you can see that the 49% is the L858R, while 51% is deletion 19. And on the right hand side, you can see that it was done on 303 subjects. So this is the current testing and treatment pattern. Prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous NSCLC. This is a result from an early EGFR study presented in ASCO 2023. So you can see here that the surgical resection decreases as the stage increases. So for stage 3B, the percentage of patients who underwent surgical resection was 28%. Stage 3A, it was 33%. Stage 2B was 58%. Stage 2A, 61%. Stage 1B, 72%. Stage 1A, 96%. And overall it was 73.2%. So more than two-thirds of these patients underwent only surgical resection. Patients with stage 2 or 3 NSCLC, only 46.3% patients received adjuvant systemic therapy. So, after initial treatment, more than half of the patient with resectable NSCLC experienced recurrence within 5 years. And these patients, they underwent surgery, they underwent chemotherapy or radiation, as was the guideline at that point in time. 40 to 50% patients remain cancer free, while 50 to 60% they recurred. And you can see that the patients, they had local as well as distant recurrence. So given that over half of the patient recur after curative intent surgery, there is an unmet need for the improved neoadjuvant and adjuvant treatment options in order to improve outcome. So this is the Anita study presented in 2006 when the LACE meta-analysis came. And this was the adjuvant chemotherapy after surgery for stage 1B to 3A NSCLC. And it showed that the adjuvant chemotherapy, it improved disease-free survival by 5% after 5 years. So there was the improvement in the overall survival, and there was improvement in the disease-free survival as well. So you can see that after 5 years, the DFS and OS was 5%. The p-value was 0.017 for overall survival, and it was 0.002 for disease-free survival, and fairly good number of patients, almost 407 patients in the chemotherapy arm and 433 patients in the observation arm. So these were the adjuvant EGFR mutation and SCLC setting treatment, in which various drugs were used. So we will go through them one by one. And these all did not translate it into the approval or change in the clinical practice in the adjuvant setting. So the one drug was lortinib, and it was the SELECT trial, which gave lortinib for the EGFR mutant patients in stage 1 to 3A after surgery versus chemotherapy alone, or chemotherapy plus lortinib in those patients who had EGFR mutation. And the RT was also given as per the need of the patient. The total number of patients were 100. 2-year DFS was 88% versus 76% for the historical control. For the Radiant trial, it was stage 1B to stage 3A EGFR mutation or amplification. They were also taken. And these patients, they were given a lortinib versus placebo after adjuvant chemotherapy. So the clinically meaningful DFS improvement in EGFR mutant subgroup was seen, and it was 46.4 months versus 28.5 months. Similarly, this was Ivan study. Ivan study, enrolled patient with stage 3A EGFR mutant, and these patients, they were given erlotinib versus chemotherapy. There was significant DFS improvement, that is 42.4 months versus 21.0 month, but no overall survival improvement. Similarly, this was the adjuvant CTONG 1104 study. Here, the patients enrolled were stage 2 to stage 3A EGFR mutant. Gefitinib was given as the adjuvant treatment after chemotherapy versus placebo. And the significant DFS improvement was seen 28.7 months versus 18.0 months. But here also, you see there was no significant overall survival improvement. It was 75.5 months versus 62.8 months, and the p-value was not statistically significant. Similarly, this was BR19 trial, stage 1B to 3A, EGFR unselected patients. Gefitinib was given versus placebo after adjuvant chemotherapy or radiotherapy. This did not show any DFS or OS advantage. So this is the current evidence for EGFR TKI from randomized trial in the adjuvant setting, not including osimertinib, that is ADORA trial, and there was improvement in DFS, but there was no overall survival benefit. So you can see here that all the trials they showed DFS except one, which was BR19. Uh, the p-value was statistically significant. The hazards were favorable. There were 48% reduction in the risk of disease recurrence. While the overall survival, you can see that it was not present. The hazard ratio was 0.64, but the p-value was not statistically significant. The reduction in risk of disease recurrence differed by a timing sequence of TKI. So, why these results they have not resulted in the change of practice despite having DFS benefit? So, these trials they had the limited size, design, or other factors. Uh, most of them, all of them, in fact, whether it was BR19 or CTONG adjuvant trial or Evans, none of them they showed overall survival advantage. And it is unclear if adjuvant's EGFR TKI results in cure or just delays the recurrence. So, no definite evidence on appropriate sequencing, drug, or duration of the treatment. So, in view of the clinically unmet need and the prevalence of EGFR mutation in the early stages as well, the ADORA trial was designed, and the patients with completely resected stage 1B, 2, 3A NSCLC with or without adjuvant chemotherapy, they were included. And the inclusion criteria were more than 18 years of age, WHO performance status of 0 to 1, confirmed primary non-squamous NSCLC with exon 19 deletion or L858R mutation. Brain imaging, if not completed preoperatively, should be done. Complete resection with the negative margins. Maximum interval between surgery and randomization was 10 weeks if the adjuvant chemotherapy was not given, and 26 weeks if the adjuvant chemotherapy was given. So, um, just 6 months if the adjuvant chemotherapy was given. The stratification factor was stage, that is 1B versus stage 2 versus stage 3A, EGFR mutation, exon 19 deletion versus L858R mutation, Asian versus non-Asian, and these patients they were randomized for 3 years. It was either osimertinib 80 milligram once a day or just a placebo. So the planned treatment duration was 3 years. Treatment continued until disease recurrence, treatment completion, or discontinuation criteria were met. Follow up until the disease recurrence, that is week 12 and 24, and then every 24 weeks to 5 years, and then yearly. And after recurrence, every 24 weeks for 5 years, and then yearly. The clinical key endpoints were DFS by investigator assessment in stage 2 to stage 3A patients. Key secondary endpoint were DFS in the overall population, that is stage 1B, stage 3A, or landmark DFS rate, OS, safety, and health related quality of life. So this was significant improvement in DFS, which was demonstrated in primary as well as overall population. In stage 2 to 3A, you can see that the median DFS was statistically significant. It was 68.8 months versus 21.9 months in the placebo. The hazard ratios were extremely favorable, 0.29. On 51% maturity. And in the overall population, the median DFS was 66.8 months versus placebo, it was 28.1 month. The hazard ratio was 0.27, and at maturity, it was 45%. So this adjuvant osimertinib significantly improved CNS DFS as well. So we know very clearly that lung cancer, and specifically EGFR mutated or ALK mutated lung cancer, they um, go to the brain in 40 50 percent times if we follow these patients till the death. We need a drug that is active in CNS and CNS metastasis. They are poor prognosis factor amongst patients with NSCLC and are associated with deterioration in the quality of life. So this drug has the improved CNS efficacy. Osimertinib has shown greater penetration of blood-brain barrier and higher exposure of brain compared with the other EGFR TKI. Adjuvant osimertinib demonstrated CNS DFS benefit versus placebo in both stage 2 to stage 3A and 1B to stage 3A population. So on the right hand side, you can see the ADAURA updated CNS PFS analysis in stage 2 to stage 3A. For osimertinib, it has not reached. For placebo, also it has not reached, but there is a significant gap between this, and this is still immature. Coming on to the safety analysis, no new adverse events they were noted when compared to the primary readout of ADAURA date. So any adverse event, 98% in osimertinib versus 90% in placebo. Any grade 3 adverse event, 23% in osimertinib, 14% in placebo. Any adverse event leading to the death, less than 1% in osimertinib and 1% in placebo. Any serious adverse event, 20% in osimertinib, 14% in placebo. So you remember that this is being given for 3 years. So when the drug is being given for so long, you expect some side effects. So any adverse event leading to the discontinuation of the drug, 13% in osimertinib versus 3% in placebo. Adverse event leading to the dose reduction, 12% in the osimertinib group, 1% in the placebo. Adverse event leading to the dose interruptions, 27% versus 13%. Any adverse event, 91%. So at the time of the current data cutoff for OS, January 27, 20231, additional serious one additional serious adverse event, that is COVID-19 pneumonia, had been reported, which occurred more than 28 days after the treatment discontinuation. The investigator determined that this was not the treatment related and the patient made the full recovery. So in order to improve survival, we need to put more efforts to the identifying the lung cancer early and never miss an opportunity to test for the actionable mutation if it is present. And nowadays, we are doing it with the help of NGS. And now this applies to the early lung cancer also for EGFR mutation. And the collaboration with the multidisciplinary team is very, very important to improve the survival. Patient may ask for the treatment option for best survival probability. So be ready to discuss and offer them as per the best available data. ADAURA data gives a probability of cancer patient to remain cancer free for with the survival benefit, and this is the goal of the patient and the physician. Thank you so much for patient listening. If there are any question, we can take some questions.
Thank you, sir. Sir, can we just wait 2 minutes for Dr. Abhishek sir to join?
Yes, yes, we will wait. Did you speak to Dr. Abhishek?
Yeah, Ashish sir is coordinating with him.
Surangi, hello.
Hello. Yes, sir.
You have Dr. Abhishek's slides available with you?
Yes, yes, I have. I have.
So I will present.
Okay, fine, sir. I will share the screen from my side.
Okay.
Are the slides visible, sir?
Yes, yes, there will
Yeah.
be. Please make it full screen. Yes. So good evening. I will be speaking on molecular biomarker testing in lung cancer. Next slide. Next slide. Next slide. So this is the Globocon 2020 data, and we know that from this data very well that the most common cancer worldwide is lung cancer overall, and in females it is breast cancer and cervical cancer. In males in India, we have head and neck cancer as well, but the lung cancer is the most common cause of death as well as prevalence in overall world. Next slide. Next slide. Next slide. So 50% of the patient with adenocarcinoma, they have driver mutation, targetable mutation with FDA approved agents on the clinical trial. And this is a good number. We have plenty of oral TKI available nowadays, which work very, very extremely well for these mutations. So we have EGFR mutations in approximately 17% patients, KRAS mutation 25% patient, ALK 77% patient, then MET 3% patient, then less than 3% are HER2 new, ROS, BRAF, RET, NTRK, PIK3, and MET1. So we have different targeted drugs which are available for these mutations. Next slide. So it is very important that we do the biomarker testing in non-small cell lung cancer. All the studies they have showed that the patient who have identifiable, actionable, targetable mutation and they receive appropriate targeted therapy, they have improved outcome. Next slide. So all the guidelines, whether it is NCCN, ASCO, ASMO, or CAP guideline, they all recommend doing biomarker testing, EGFR, ALK, ROS, BRAF, MET, RET, NTRK, KRAS, and PDL1 testing for all the patients who have stage 4 NSCLC. Next slide. So these are various methods with the help of which we can do NGS testing. So these are DNA sequencing with the help of NGS or PCR. RNA sequencing panel specifically detects the fusion abnormalities like ALK, ROS, RET, and NTRK. IHC or FISH for ALK and ROS. So if you are not doing RNA sequencing, that then you can miss a few of the ALK, ROS fusion abnormalities. Next slide. Next slide. So this is how the patient proceeds from the biopsy to the analysis. Once the patient is identified, then either the tissue or cytology or the liquid biopsy with the help of blood or cystic fluid, it undergoes the processing and then fresh FFP blocks they are made. Histology is read and then DNA extraction is done. With the DNA extraction, we do ancillary testing such as PCR, MSI, whole exome sequencing, or RT-PCR or RNA sequencing. Um, the key personnel involved, they are pathologists, laboratory staff, clinical informatics, and bioinformatics. Next slide. So establish the diagnosis, determine the histology, and then biomarker testing is done. It can be done for the primary tumor or metastatic tumor, whichever is easily accessible. These bone biopsies, they can be sometimes suboptimal due to decalcification or degradation of the tumor. Test for EGFR, ALK, ROS, BRAF, NTRK, RET, MET in all non-squamous NSCLC. Test for PDL1 expression in NSCLC and complete the test within 10 to 14 days of the biopsy. Next slide. ctDNA has the potential to apply across all the stages of NSCLC throughout the treatment pathway. Next slide. So can help in diagnosis and treatment selection. It can help in monitoring the prognosis, uh, response to the treatment, and progression of the relapse. Then ctDNA can result in the testing result in the overcoming some of the major challenges associated with the tissue testing, and it may never replace the tissue biopsy entirely, but could have the complementary role to support the treatment selection. Next slide. Next. 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 So it can be used to detect MRD as well after the surgery in resectable and SCLC. And the concept of MRD comes from the hematological malignancies like leukemias and myelomas. If there is presence of MRD, then it can predict the disease recurrence. Currently, MRD cannot be identified using traditional diagnostic methods. As detection of ctDNA in the plasma indicates the presence of residual tumor, it can be used to measure MRD. And in the TracerX study, the ctDNA profiling was able to confirm the MRD negativity and detect MRD in the patient who relapsed before the disease was picked up by the standard imaging. Next slide. So this is the comparison of the tissue versus liquid biopsies. There are similarity and differences. The sample acquisition is sometimes a problem. You need the biopsy for the tumor tissue, but for liquid biopsy, just a simple blood. Repeat testing is sometimes difficult. If you are testing the tumor again, you need the repeat biopsy, but it is a liquid biopsy is a simple non-invasive test. The correlation with the histology and cellular phenotype is possible with the tumor biopsy, but it is not possible with the liquid biopsy. The sensitivity of the assay required, the lower tumor fraction content is acceptable for if you are using the tissue for the biopsy, but the liquid biopsy, very sensitive methods such as ctDNA should be needed. Analytical standardization is it is present for the tumor tissue, but not still present for the liquid biopsies. Um, Evidence of the clinical utility is still less for liquid biopsy. It is substantial for the tumor tissue. Next slide. Next slide. Next slide. So, whether we should be going for the multiplex gene sequencing or single gene sequencing, the answer is yes, it should be multiple genes sequencing, multiplex PCR or DNA NGS or RNA NGS should be done rather than a single gene reflex testing, which can take the time, which can lead to the loss of the tissue and not the further testing. Next slide. Next slide. Next slide. So these are the advantages of NGS. It has a number of advantage. The ability to evaluate all the known molecular alteration in the single test gives NGS a major advantage. If many molecular testing are needed, such as in lung cancer, NGS is probably better. The cost is less if we use NGS as compared to single gene sequencing. But the turnaround time is sometimes a problem in NGS. Usually we find the report not before 2 weeks time, but for single gene sequencing or testing by IHC or PCR, you can get report in 2 to 3 days. Next slide. So these are the advantages of doing various kind of testing, which include single gene assays, Sanger sequencing, pyrosequencing. These all can detect SNVs. CNVs, they are not detected, but with the help of FISH, you can detect CNVs. With the help of NGS, you can see that you can both detect SNVs as well as CNVs. So the choice of assay is next generation sequencing. Next slide. Next slide. So EGFR mutation in lung cancer. Next slide. So the FFP sections, they are used. They are alcohol fixed specimen that can be used for PCR based assays. The cytology samples are also suitable. Cell block are preferred over smears. Discordance between EGFR mutation status in primary and the corresponding metastatic site is very, very rare. So you can use either of the sample, either from the liver or a lymph node or lung versus the primary tissue in the lung. Next slide. Next slide. So NCCN recommends testing for NGS for EGFR mutation testing in early stage lung cancer as well, because we have the data available from the Aurora trial. Next slide. Next slide. So what are the advantages of NGS over PCR? One study showed that 48% of the EGFR exon 20 insertions mutation they were identified via NGS are missed out on the PCR. And out of 17 most common EGFR exon 20 insertion mutation variant, only 4 can be identified via PCR. Next slide. Next slide. So the false positivity rate for ALK is 0.1% with fish, but IHC is 93 to 100% specific, sensitive and specific as compared to fish. It is less expensive and hence more widely adopted. Next slide. ROS1 rearrangement. Next slide. So this is the algorithm for predictive genetic testing for ROS1 in advanced NSCLC. Next slide. Next slide. So coming on to the c-Met receptor tyrosine kinase and MET exon 14 skipping mutation in NSCLC, it has got a normal role in embryogenesis and the wound healing. In cancer, MET14 skipping mutation causes in-frame deletion of the gesta membrane domain, resulting in the increased stability and constitutive kinase action. And the majority of these skipping mutation can be detected with DNA NGS, but increased sensitivity with RNA NGS is seen. Next slide. For MET exon 14, IHC is not recommended, FISH is not recommended. NGS is design dependent and potentially detects many mutation, and RNA NGS is the most sensitive NGS for exon MET amplifications. Next slide. Coming on to the RET, it has got the normal role in neural genitourinary development, and the majority of the RET fusion can be detected by DNA NGS, but increased sensitivity with the RNA NGS. Next slide. So for RET fusions, they can be detected with DNA NGS, but the increased sensitivity is with RNA NGS. So we have to choose a uh, method which has got the RNA NGS as well. Next slide. Coming on to the anti-RK fusion. So this is the fusion like the RET and the RNA NGS, they are most sensitive. Reflexing to NGS with versus IHC is reasonable for NSCLC due to low prevalence of anti-RK fusions. Next slide. So you can see the various methods for anti-RK fusion detection, IHC, FISH, and NGS. But in all of them, the best is to use NGS as it has got more advantages over IHC or FISH. Next slide. HER2 new mutations in NSCLC is seen in 3 to 5% patients. Mostly they are exon 20 in-frame insertions, mutually exclusive with other mutations. Mostly seen in never smoker. In NSCLC, HER2 mutation and amplification must be identified using a NGS DNA panel, and the IHC used to assess HER2 overexpression seen in 59% of the NSCLC cases. Next slide. So this is the 2022 treatment paradigm for molecular marker positive NSCLC. You have EGFR mutation, then the
Hello,
choice of treatment is osimertinib. For uncommon exon 20
हेलो
insertions,
सर,
the
मैंने ग्रुप
amivantamab.
पे डाल दी थी और मेरे दूसरे कलीग ने भी शेयर।
Then for ALK, it is alectinib, brigatinib, ceritinib, or lorlatinib. ROS1, crizotinib, or entrectinib, BRAF, dabrafenib and trametinib, NTRK, fusions, entrectinib and larotrectinib, RET, selpercatinib, MET, capmatinib, or tepotinib. Or for KRAS G12C, it is sotorasib. Next slide. Next slide. Next slide. So the PD-L1 antibody clones which are available are 22C3, SP263, SP142, and 28-8. So the companion kit for the pembrolizumab is 22C3, durvalumab it is SP263, atezolizumab SP142, and for nivolumab it is 28-8. Next slide. Next slide. Next slide. So PDL1 score is the current biomarker to able to guide immunotherapy. Then the other biomarker for immunotherapy is TMB, which is currently not used much, but we have the approval for pembrolizumab for TMB high patients. MSI is another, but it is still not very significant in lung cancer. We hardly find patients with MSI high. And then LAG3, it is the possible mechanism of resistance to immunotherapy. It is being studied. Next slide. So biomarker testing has evolved from single gene to multiplex testing. Multidisciplinary teams meetings are needed to better identify the sample and test requirement. Sample should contain adequate tumor content, at least 10%. Ideal turnaround time is 2 weeks or 10 days in best case scenario. And the Howie Therapeutic platform such as NGS are to be used to screen the several genes at a time to provide the result within the estimated TAT. Next slide. So these are the various methods which we have already discussed for various kind of mutations. Next slide. Thank you so much for your patient listening. If there are any questions, we can take few questions.
Thank you so much, sir.
So if you have no questions, we can close the meeting.
Yes, sure, sir.
Thank you so much for joining.
So I would like to thank everyone for giving their wonderful talk on each and every topics. So we'll meet you again soon. Good night. Technical team can